Check 1 2. Check 1 2. Check 1 2. No? Yeah? Okay.
Sorry about that. We'll start this again. Welcome to the Standing Committee on Social Development public briefing on long-term care waiting times. Before we introduce ourselves, I'd ask Mr. Boley to open up with a prayer.
So thank you, Mr. Chairman. Mr. Chairman, I'm going to do a prayer in my language for the in Chippewa. Merci, Duritsi and Nilsen. Tatanyas Tiha, don't alternate, no need third word, you let coin not had a coin than a party. Had the tot hill, corn had you shine there. Had to night here to Minister of Health and Social Services, how the real curl, that who nether, that you alternate a coin had law high, you have here. And Nilsen, mercy, mercy, no alternate had to say, mercy, amen.
Thank you, Mr. Boley. Before we get started, I'll ask our members to introduce themselves, and then I'll turn it over the floor to Minister Abernathy to introduce himself and his staff. I'll start with Mr. Boley.
Thank you, Mr. Chairman. My name is Tom Boley. I'm an MLA for Tuneda Willady.
Good morning. My name is Michael Nadley, MLA for Decho.
Kevin O'Reilly, Frame Lake.
Thank you. My name is Shane Thompson, Chair of the Social Development Committee, and I'm from the Nahende. I represent the Nahende. On my left is our research analyst, Megan Welsh, and on my right is our clerk, Jennifer Frankie Smith. I'll turn the floor over to yourself, Mr. Abernathy.
Thank you, Mr. Chair, and thank you for the opportunity to meet with you today regarding long-term care wait times and the Territorial Admission Committee, the process that we utilize to place individuals within long-term care. I look forward to sharing this information about our long-term care program, and I hope that it'll give a bit of a better understanding of the complexity of planning to meet the long-term care needs of seniors and elders in our communities, and the complexity of actually placing individuals within our long-term care facilities. I have the following staff with me this morning. Ms. Joanne Hubert, who is the Assistant Deputy Minister of Health Programs. Ms. Victorine Lafferty, who is the Director of Seniors and Continuing Care. Ms. Kate Sills, who is the Senior Advisor to the Deputy Minister. And Susan Laramie, who is my Special Advisor. Mr. Chair, committee knows that seniors are the fastest growing age group in the Northwest Territories, and we have to work together to meet the social needs of our elders and seniors. This is an essential goal for this government. The aging population will continue to increase the demand and utilization of healthcare facilities and services throughout the Northwest Territories. We also know that elders and seniors care can be very complex and often requires a greatest level of care. Within the Continuing Care Action Plan, which I know members have seen and have had some input in, we continue to improve our long-term care operations so we can meet the elders and seniors' needs when they can no longer care for themselves at home. This is one of the many activities we are undertaking to support the current mandate of the Government of the Northwest Territories, and we're focused on finding ways to help seniors age in place, recognizing that some of them will need additional supports like long-term care at some point. I would like to ask now that Ms. Joanne Hubert to give us a bit of a brief overview of the long-term care application and admission process, as well as some statistical data to show where we are now and sort of articulate where we're going. Thank you, Mr. Chair.
Thank you, Mr. Abernathy. Ms. Hubert, presentation.
Thank you, Mr. Chair. So I understand that you have the slide deck in front of you. The first 5 slides are really information that you do know. We've provided this information to you in the past, and it's really just to set the stage and provide some background. The purpose of the presentation today, as Minister Abernathy has mentioned, is really to focus in on the Territorial Admission Committee process, as well as what is happening with our long-term care wait times, and in particular, looking at what we're going to do in the future. So I'm going to ask that you actually, you can definitely look at, you've had the slides prior to today, but let's turn to page, slide number 6, which is titled Aging in Place. So this slide, the main point on this point, we know that our priority and the priority of this government is to ensure that we are helping our elders and our seniors live in their own homes in their communities as long as possible. One of the things that is really important in relation to long-term care is to understand that it is not seniors housing. It is for individuals who have complex care needs and that cannot be met in their home and communities. So if you look at the next slide, I want to walk you through this slide. It's a little bit busy, but I think it will help set the stage to understand the continuum of care. So as our elders and our seniors age and their needs become more complex, there are a number of ranges and levels of care that they would move through. So for example, independent housing, often the transition may be that an elder or senior will go from their home into independent housing. Independent housing is a program or an opportunity for seniors and elders that is actually, we work with our partners in the Housing Corporation. That is not actually run by Health and Social Services. So then some of the other options are home care, supported living, long-term care and dementia care, as well as extended care. And that continuum is over 5 to 6, actually 6 levels of care. Particularly long-term care, what's important to note is the long-term care facilities that I will be speaking to in this presentation all deal with level 3 and 4 care. And we have extended care unit, which is an acute care, an arrangement whereby individuals end up at a level 5. So I just wanted to point that out for you. I know it's a little bit busy on that slide. So if you move to slide 8, I want to talk about demystifying the wait list. So the availability of long-term care beds can be different for an individual based on their home, the bed type, the eligibility criteria, and of course according to their individual needs. The long-term care wait list is not managed on a first-come, first-served basis. I think that's really important to understand. And one of the things I will share with you in comparison to some of our colleagues in the South, that clients sometimes in the South apply for long-term care to be on a wait list in case they need to have care at some point in the future. In the Northwest Territories, and I will walk you through this process, the care needs are actually based, the placement on the wait list is based on the care needs. So sometimes clients will actually be on the wait list longer if they have a lower care need. And as we go through the presentation, I'll help provide some clarity to that. The placement is based on a professional assessment that includes nursing, their health care needs, of that individual care needs, and recognizing that their care needs change over time. If you look back, remember the last slide we just looked at the continuum of care, sometimes clients will actually go through all 6 levels of those levels of care, and other times they'll come in at a different time into the wait list. And clients on the wait list, as I mentioned, in lower care needs will wait longer. And this is captured in the median wait time once they receive an offer of placement. So if we look at slide number 9, this is actually the Territorial Admissions Committee. So the committee is, it's a streamlined process that was established by the government of the Northwest Territories and our minister back in 2009. The members of that committee, there is a chair, which is the department's manager responsible for continuing care. There are 4 representatives from our Health and Social Services authorities where we do have the location of our long-term care facilities, and they sit at that table on a rotational basis. We have 2 departmental staff which help provide program support as well as admin support, and those are from long-term care, home care, or supported living. And there's also a public representative that sits at that table. The committee meets on a monthly basis, and they review the applications that are complete and that are submitted to the committee. and there is an opportunity for clients and their families to appeal the decision to the deputy minister. So what happens in that process is the primary care and home care providers in the regions work with the families to help complete the application. And it is the case manager, and that can be a nurse or it can be a social worker, depending on who actually is taking the lead for that family to help facilitate that process for them for the application to the Territorial Advisory Committee. And the TAC, Territorial Advisory Committee, also known as TAC, follows a first available bed policy where beds are given to the clients on the wait list who have the needs, the greatest needs for that bed. And it is based on need, and it's also based on urgency. So, and if you turn the page, and we will go to slide number 10, we're going to look at the objectives of the Territorial Advisory Committee. So, in the previous slides that we skipped over, one of the things that we want to ensure that the programs that we establish are equitable access for all seniors and elders, and that principle applies to long-term care, and recognizing again that it is based on needs. The TAC has developed policies and procedures whereby it provides an efficient referral and a review process for the applications. And of course, we want to ensure that as the applications are handled and managed and transferred from the health authorities to the Territorial Admissions Committee, that that information is maintained confidentially. I did mention that there is an opportunity for reassessment. It's important to note that when clients and their families apply for admission for the wait list, that they don't just sit there and never get looked at again. There is an opportunity where if their care needs are increased or change over time, the Territorial Admission Committee works with the case managers to ensure those individuals' care needs are reassessed and the applications are updated. And of course, if there is nothing that happens with one of the applicants that's sitting on the wait list past 6 months, that's a trigger for the Territorial Admission Committee to also go back to the case manager and touch base with them to ensure that the individual's care needs have not changed. And so they will also, so it can happen at both ends. The case manager can trigger a review and a reassessment through the family, and the Territorial Admission Committee will go back to the family and the case manager to ensure a reassessment occurs after 6 months. So if we look at slide 12, and this is a little bit of data around our current wait times. We have 8 facilities that the Territorial Admission Committee manages, and that is on a territorial basis. We currently have, as of January 2018, we have 31 individuals who, within the community, and what the community means, these are persons that are residing either in their home or they may be at an alternate level of care. And an alternate level of care means they actually are in acute care, sitting in a hospital bed, whereby their needs have exceeded the ability for the community or their family to look after them. And so those would be considered individuals that are sitting within the community. So either in their home, in the community, or in an alternate level of care. We also have 4 individuals that are on the wait list that are awaiting transfer. And what that means is that can be at the individual or the family's request, or it can be based on increased care needs whereby an individual has been identified through reassessment that their care needs have changed and it would be more appropriate for them to transfer to a different facility. So that is a snapshot of the wait list. Some of the factors that are important to know around the wait list that impact the wait list are, first of all, the number of individuals on the wait list is an indicator of the demand for long-term care, and we're looking at slide number 13. This is affected by a number of things, but most often it's the ability of the family to look after their loved ones, and for the health and social services system to provide support to that individual to age in place. So currently, our median wait time on our wait list is 58 days, and this is for admission into a long-term care bed, and that means that half will wait longer and half will wait less. The next slide, on slide 14, is a breakdown of our NWT long-term care beds. So we have a total of 183 beds between 8 facilities, and 167 of those beds are actually long-term care beds, which the Territorial Admission Committee will review for placement, and that is the 167 beds. We actually have 16 respite and/or palliative care beds, and those beds are managed by the facility themselves. Those are not administered, or the Territorial Admission Committees does not actually review those files for placement into respite or palliative care beds. Those are managed by the individual facilities. So if we look at slide 15, this is an analysis of our wait times. So on average, since 2010 to the end of this last fiscal year, the Territorial Admission Committee has reviewed, on average, per month, 6.5 applications, and it does range between 3 to 14 applications typically over the span of each month that they review those files. I had mentioned to you that the median wait time for 16-17 was 58 days, and I've explained to you that that means half will be above that and half will be below that range. And some individuals will wait for placement for a long time. And one of the points is about the care needs. So if they apply early and they have low care needs, they are going to wait on the wait list for longer than an individual who may come in to the process at the level of care around a 3 or 4, which is what long-term care currently houses. We currently have 31 individuals on our wait list. 14 of those individuals, which is 45%, have been offered a bed and have declined. 5 of the individuals have been offered an interim placement, and I'll explain to you in the next slides what that means. 3 of those individuals have accepted that placement, and 2 individuals have not accepted that placement. And not all the clients who have declined placement have low care needs. So their care needs may be variable, and we're not sure exactly yet why they have declined the offer, but for their own personal reasons, they have chosen to decline an offer. So of the 31 individuals on our wait list, 19 of them have received an offer for placement. These next slides are very technical. I have them in your package. Again, you're welcome to refer to them at any time. The median wait time, as you can see in the slide 16, there has been a gradual increase in the median wait time, and that would make sense because we have had a higher demand for long-term care as our seniors continue to age, and we recognize we have a demand and therefore have invested in building an infrastructure for long-term care in the future. The slide 17, again, wait time is an indicator of access. This is broken down by facility, so between 2014 and 2017, you can see what would have been the median wait time by facility on slide 17. Slide 18 is actually the slide that looks at the levels of care and in relation to the wait time. So I had mentioned earlier that all of our long-term care facilities, with the exception of extended care unit, are all level 3 to 4. And then you will note that based on our wait list, these are the numbers whereby the folks are waiting for those particular facilities. So let's look at slide 19, which is the actual application process. So clients whose care needs are no longer to be met at home will work with their case manager. I mentioned that could be a nurse or a social worker to fill out the long-term care application. So that is a collaborative between the family, the client, and the case manager. They submit the case manager actually submits the application on behalf of the family and the client to the Territorial Admission Committee. The details is it's secure, and that's to ensure patient confidentiality. The Territorial Admission Committee will look at that application. They provide the admin support, and the biggest key to that is they want to ensure that that application is complete. By far, one of the reasons, most common reason why individuals do not end up on a wait list is because the application is not complete. So our Territorial Admission Committee and our staff will ensure that they are going back to that case manager and assisting them to provide that application so that it can be complete. The Territorial Admission Committee then reviews the application. Again, I mentioned that that is monthly. And then they notify the case manager in writing what the person's eligibility is for long-term care. The next two slides are busy and detailed, and I will walk you through that quickly just to explain to you what is the process when a bed becomes available. As you probably are aware, it's pretty rare to have long-term care to have discharge from a facility, and unfortunately, the most common time as to why a bed becomes available is because somebody has passed away. So when that bed becomes available, that facility actually notifies the chair of the Territorial Admission Committee. They don't wait until the meeting for that to occur, by the way. The meetings happen monthly, but if should a bed become available, they don't have to wait for the meeting to occur because they already know who's on that wait list. The chair then reviews that wait list to identify the client with their highest needs. Again, recognizing it is the highest needs, it's not the place the individual, it's not about when the individual may have applied for the Territorial Admission Committee, for that facility. The case manager then notifies the Territorial Admission Committee, we'll go over here. They provide an offer of placement for that client via the manager. The manager then works with that family and brings that offer to that client and the family. The case manager then tells the Territorial Admission Committee what their decision has been, and if the bed is accepted, the case manager notifies the facility, and then once the placement has occurred and that individual is admitted into the facility, they are then removed from the wait list. The next slide is, the piece of this that is important to know is about when a bed becomes available and there's no one on the wait list for that facility. So in that scenario, if you move down and we look at the Territorial Admission Committee process is exactly the same. They then offer an interim placement for that individual to go to a facility that might not have been the one that they had wished for or close to their community. They provide that on an interim offer. That individual, in short, remains on the wait list. If they accept the interim offer, when a bed becomes available in their community of preference, they then have priority to receive that bed as the first time that it becomes available. If they choose to take this interim offer and go to the facility that might not be their choice, those individuals actually remain on our wait list compared to the previous process where I noted that once they were admitted to the facility of their wish, they are removed from the wait list. So they remain on the wait list to such time that either they remain in that facility and that is their wish, or a facility becomes available based on their preference, and then they move into the facility of their preference, and then they're removed off the wait list. I know that those are two very busy slides, but that is, in short, the step-by-step process. And the remainder of these slides, these next slides, are technical. It talks about the average length of stay, and you can see that there's a trend from 2014 to 2017. Some of that has changed over time, and that's based on the Territorial Admission Committee and the process that has been put in place to streamline admissions. And it also has changed because historically there has not been a great demand for long-term care facilities, so folks potentially with lower care needs may have been in our facilities longer compared to today when there's a higher demand. We also monitor our occupancy rates over time. That's just a standard that we do monitor. And the last slide that I would like to share with you is some of the future initiatives. As you recognize that the Territorial Admission Committee and the long-term wait times are at one end of the spectrum, but of course we also have this priority to ensure that we are wanting to maximize our clients, our elders and our seniors to be able to remain in their communities and their homes and age in place. So we have a number of capital investments whereby we, as you're aware, we are planning to build additional long-term care facilities. We are proposing a regulatory framework around long-term care. We are enhancing our home and community care services, and you would have seen this through our continuing care services action plan. We are also introducing a paid caregiver, and we're in the research component of that part of that process. And we are also implementing Interi, which is a client assessment tool, which is evidence-based. Even though the Territorial Admission Committee, the assessment tool is standardized, it is a paper format, and it is subject to subjectivity. So we're looking to implement an Interi evidence-based electronic tool to streamline that assessment process. And we will continue to work with our partners, particularly housing, around independent housing, and for our seniors, and looking at marketing our preventative maintenance and mobility renovations and upgrades as needed. Thank you, Chair.
Thank you, Ms. Ebert.
I know that was quick.
Oh, no, it's well-informed. Answered some of my questions I had jotted down, so thank you very much. Mr. Bolio.
Thank you, Mr. Chairman. Mr. Chairman, I'm wondering if the department could expand on the mobility, how do you say, I guess retrofits that are paid by Health and Social Services as opposed to the Housing Corporation.
Thank you, Mr. Bolio. Minister Abernathy.
Thank you, Mr. Chair. Mr. Chair, for us, I mean, this is primarily about long-term care and the Territorial Admission Committee. We're committed to supporting aging in place here in the Northwest Territories, and we're moving forward with a number of initiatives to support that. The Housing Corp does have some programs to help people retrofit their houses. We have the ability to have occupational therapists when there's a direction from a practitioner or a doctor to do so, to come into people's homes and help them identify things that they can do in their homes, grab bars, other support mechanisms, those types of things, so that people know what they need. We don't have a program that necessarily pays for these things straight up. Some individuals can access different pots of money, whether it's insurances or other things, to do those types of things. So those are the types of things that we're continuing to look at to see what we need to do in order to help people stay in their house. The best results will always be to help people stay in their homes first, their communities second, for as long as possible. The long-term care study that we did was premised on doing more around aging in place and helping people stay in their homes and communities first. Long-term care is still going to be necessary, even if we are far more effective at aging in place. So this presentation is more focused on the TAC.
Thank you, Minister Abernathy. Mr. Bolio.
Okay. I don't really have a lot of questions on the admissions committee, but do have other questions about the rollout, which I guess they all tie together, the rollout of the caregiver program. Right now, I'm encountering situations in my riding where individuals are staying out of long-term care because I have people living with them that are supporting them, but they themselves need support. The caregivers themselves need some support. They're not able to provide that because they have to work also. So I'm wondering if I could get some sort of a timeline from the department on when they think that a program like a caregiver program would roll out.
Thank you, Mr. Bolio. Minister Abernathy.
Thank you, Mr. Chair. Mr. Chair, there's many different models that we're exploring and looking at, whether it's a family caregiver or whether it's somebody else in the community. And I think we need to be open to all those options, recognizing that there is no such as one model fits all. The department is doing the research on best practices in other jurisdictions right now. We do have some dollars that we've been able to get from the federal government that are helping us do some of the design work on this. We're hoping to be in a position where we could start piloting some of these concepts during the 18-19 fiscal year. I'm cautious about throwing out a date because, if I said it's going to be in the first quarter and it's not until the second quarter, then we will have missed. We want to make sure that the pilots make sense when we roll them out, and there's lots of variety. I will keep committee up to date regularly on where we are and where we hope to be going. And I hope to have more concrete dates as we move along.
Thank you, Minister Abernathy. Mr. O'Reilly.
Thanks. Yeah, I appreciate the presentation. It's helped clarify a few things for me, but The one sort of side of things that really wasn't dealt with a lot is what happens when someone refuses an offer. Do they stay on the list? Do they go to the bottom of the list, or they are taken off the list for a while, or what happens what's the outcome there? Thanks, Mr. Chair.
Thank you, Mr. Riley. Minister Abernathy.
Thank you, Mr. Chair. I'm sorry that wasn't as clear as we had intended. They stay on the list if they don't accept one of the offers. And one of the reasons people will tend to not accept the offer is if it's not in the facility of their choice. For instance, we might get an individual who really wants to be located in Avens because they live in Yellowknife, and there may not be an opening for 6 to 10 months, but there might be an opening in Betchco or Fort Smith. And we will have made them, due to their acuity, an offer in Fort Smith or Betchco, at which point they would decline. They do not change the list. Their acuity hasn't changed. They stay on the list in the same sort of place, assuming nobody with higher acuity comes ahead of them. They would be offered the next appropriate place, which they might also turn down until they get the facility of choice.
Thank you, Minister Abernathy. Mr. Riley.
Yeah, thanks. I appreciate the response. I know that's different than some other jurisdictions, which is a good thing. I don't know, what sort of lessons can we learn from those refusals? Obviously, and the minister has presented a plan to build and more long-term care beds throughout the territories. Is that the answer here? Is just making sure that there's more long-term care beds available in each of the regions? Or are there other ways that other things that we can learn from this? Thanks, Mr. Chair.
Thank you, Mr. Riley. Minister Abernathy.
A couple things. In many southern jurisdictions, there's a lot of private providers. And private providers are basically not, determining entrance based on acuity or need. They're based on, market and other things. I could see in some of those situations where someone might fall off our list. That's not the way we do things. We have people who have a need. We're committed to working with our residents. We don't take them off the list. We keep them on until we get them in. Sometimes that's longer than people would like. We appreciate that. But that speaks to everything we've been talking about as a mandate priority of this assembly. We've moved forward with a aging in place strategy. I think that is incredibly important to help us support our seniors as they age to stay in their homes and their communities. We need to do more. Historically, we have probably had people in our long-term care facilities who, from acuity point of view, probably didn't need to be there, but they didn't have options. So we're trying to make options. We're trying to keep people out of long-term care. Regardless, even if we do far better than we are, and we're intending to do far better, still an aging population, and there will always be those individuals whose acuity gets to a point where it's not safe for them to be living independently, which is also why we've moved forward with the 258 beds. The lesson is we know what's coming and we need to be ready, and we're trying to be ready, and we're trying to get ready now.
Thank you, Mr. Abernathy. Mr. Riley.
Thanks. Yeah, I appreciate the minister's response. Do we actually track refusals? And then by region or where the applicant lives and so on? And is that the basis then for, in the capital budget, there's going to be a new facility built in Hay River. And I think the next one on the list is a Nuvik, if I remember correctly. So that demand, is that based on the refusals, or how do you schedule and figure out where to put these facilities? Thanks, Mr. Chair.
Thank you, Mr. Riley. Minister Abernathy.
I know refusal is the right word, but it's not exactly the right word. Individuals have filled out their applications, and if they're in location X, they have likely put location X as the place they'd like to be located. Yellowknife, Simpson, Hay River, Fort Smith, and Nuvik. In a couple months, Norman Wells. And due to demand, those facilities didn't have a bed open, so they were offered a bed somewhere else, and they didn't feel it was appropriate for them in their particular situation. They didn't want to move. I think we can all appreciate that. The long-term care demands are based on an analysis put over this entire territory based on where populations exist and where our populations are aging. We know there's a major increase in seniors in places like Yellowknife. We also know the Beaufort Delta is experiencing some high number growth. South Slave has got some high experience growth. And then you compare that to where we have beds now and look at, you know, where the demand's going to be. Based on that, we've determined that as far as rolling out, we need to address the 120 beds in Yellowknife. We're doing that with the 72 in the old Stanton building as a starting point. We also have pretty heavy needs in the South Slave, which is why Hay River is an appropriate location. Simpson has demands. We're looking at incorporating Simpson in with a health center as well. So we're looking whether we have to tear down what's existing there and build 48 new, or whether there's an opportunity to expand, and how it's going to incorporate in the health center. There's a lot of opportunity there. We want to make sure we get it right. And there's high demand in the Beaufort Delta. There's lesser demand in places like Fort Smith and Betchico, and we're hoping to capture those areas in the second round, because the numbers are going to continue to grow to 2034. Our current plan is a 10-year plan.
Thank you, Minister Abernathy. I just have a couple of questions. Well, actually, the first one, when we talked about the 31 on the waiting list, 19 have declined the offer being made, and there's 12 that are out there. On slide 12, we had vacant beds. We have 6 vacant beds from that slide. So I'm trying to understand the logic of the 31, 19 decline, and still 12. We still have 6 vacant beds. So what's happening with those beds, Minister Abernathy?
So in a situation like that, it might be that we have offered those beds to somebody already, people on the list, and we may not have people from those communities who want to go into those beds, and we have people from other communities who don't want to move.
Okay, thank you. That explains the 19, but there's 12 that still are on the waiting list. That you said the 19 have declined. What is happening with those 12? Because I'm sitting here, we've got 12 here, and we have 6 beds. And so are they offered these beds in the interim, or?
We'll go to Victorine for the detail on that.
Okay, Ms. Lafferty? Oh, you don't have to push your buttons, Ms. Lafferty.
They'll do it for you.
They'll do it for you. Just can move your mic towards it. Yeah, there you go. Thank you, Ms. Lafferty.
So, the other 12 on the wait list are, they haven't been offered a bed, and they haven't declined placement. A bed hasn't come available in the community of their choice. Where there's vacancies right now is with the new beds that have opened up in Betchico. And there's some that are very clear that they have no interest in going to Betchico for long-term care. So, you know, they haven't been made an offer of placement in Betchico. And there's 2 that have accepted interim placement in Betchico and are waiting to come back to Yellowknife. And there's still 4 beds in Betchico that we're starting to see more short stays there for respite while those beds are vacant.
Thank you, Ms. Lafferty. Minister Abernathy.
And just as a note, the slide on page 12 is a point-in-time slide. So it could be that they were vacant and they were going through the process at that particular time. I'm happy to get some more details. But bottom line is we are working to keep all the beds full as often as possible. From time to time, depending on the state of a room, we might close a room for a couple weeks in order to do any sort of necessary cleaning, or if there's painting required to make sure that the room is still up to a high standard. I can't say that that's why these 6 are, but they were point in time. They're likely different today.
Okay, thank you, Minister Abernathy. Clears up a little bit, but again, if there's 12 that haven't been offered, and even though they don't wish to have those beds, I think we shouldn't still making the offer, and I think that's what you guys are doing, if I'm correct in understanding your presentation. So my next question is, in looking at these long-term care beds, and that we're finding unique situations where a husband and wife are, you know, one's a 3 or 4 and one isn't, but they want to be together. And has the department looked at addressing that concern with this waiting list, and or do they just say, just deal with the client as level 3 or level 4? Thank you, Minister Abernathy.
Thank you, Mr. Chair. Just back to your previous question, we work hard to not have any empty beds, recognizing that there are periods where there'll be short-term empty beds. But our goal is to, if there's a bed, there's an offer, and keep them moving, keep them full. With respect to couples, if we have a couple who's gone through an assessment and both of them are in the 3 or 4 range, our new facilities actually have the ability to have couples live in the same rooms. For instance, in Norman Wells, we've got rooms that are built side by side where a divider is available to come out so that they can live together, whether they choose to put beds on one side and a couch on the other side. It's really up to them. I mean, this is their home. But as far as moving a level 1, 2 in and a level 3 into a facility where there's demands for 3, 4s, we're still basing our placements on need and individuals who have the acuity, who cannot take care of themselves independently. We do have to factor in that if you move one sibling away, it might create a dependence or another challenge, might increase the acuity. So we try to be reasonable, we want to be reasonable. But if we have a bunch of people that can't live by their own and we've got somebody who can live on their own, we have to make the choice with respect to safety of those individuals. Keeping that in mind, our new facilities have the ability for couples to stay together if the acuity demands.
Okay, thank you, Minister Abernathy. Ms. Hebert, thank you very much for your presentation, because actually some of my questions I had were answered in the as your presentation went along here. So is there any other questions for the minister and the staff? Mr. O'Reilly.
Thanks, Mr. Chair. Yeah. I understand that the plan is to have 72 new beds in the old Stanton Hospital. Are any of those beds going to be for respite or dementia, or has that been sorted out yet? Thanks, Mr. Chair.
Thank you, Mr. O'Reilly. Minister Abernathy.
Thank you, Mr. Chair. Mr. Chair, at this point in time, we're talking about the long-term care beds, not expanding the number of dementia beds. That is certainly a conversation that's going to have to be had, recognizing that we are going to have some additional challenges there. And if you look at statistically, one of the areas that's under a lot of pressure is the dementia unit that we have here at Avens. We continue to look for options there to see how we can move forward in that. But our biggest demand right now is on the long-term care beds. That's where the most pressure is coming. We can put people that do have certain degrees of dementia or Alzheimer's within long-term care until they reach a certain acuity point, at which point we would have to move them into the other facility. All the buildings that we're building now with respect to long-term care, even the ones that are built now, they all have respite beds available in them as well. So the 72 will be 72 beds. A couple of those will be respite. The facilities manage respite. TAC does not manage respite. So we are including respite in everything we're doing at this point. If you look at the new facility in Norman Wells, you'll see 2 respite beds in there, 1 in each wing.
Thank you, Minister Abernathy. Any other questions? Seeing none, I will turn the floor back to Minister Abernathy for closing comments.
Thank you, Mr. Chair. No closing comments. Just thanks for the opportunity to come here and help explain what the Territorial Admission Committee is. I think there's some confusion about what it is out there, and I think it's important to get that information out into the public. We look forward to continuing to move forward with the beds we need to put into this territory. We look forward to the opening of Norman Wells. We think we'll see a little blip in our numbers, positive blip, but we know the numbers are going to keep coming. So we need to continue to move forward with our long-term care, and even more importantly, continue to enhance and build upon aging in place.
Thank you, Minister Abernathy. I would like to thank you and your staff for the presentation, and we'll just do a quick roundup. So we'll ask the minister and the staff and the public to adjourn, and we will wrap up. Thank you.
Thanks much.